So my name is Bernadette Grosjean. I'm a physician, a psychiatrist. I've been a psychiatrist in Belgium for 10 years, in Los Angeles for 20 years. Retired from Harbor UCLA, where I worked for 16 years. A couple of years ago, worked for a non-profit, no, small private practice. And in March, mid-March 2020, well, we were a month and a half into the COVID pandemic. I saw a call for help on a Facebook group for women psychiatrists I belong to, and one of our colleagues from the East Coast, Dr. Mona Massoud, was asking, would anybody want to help? I feel we should maybe put together a helpline for our colleagues, physicians on the front line. So I answer, I say, of course, I'm happy to participate. Not sure really, and I think Mona herself didn't know how it would come about and along, what would happen. And what happened is that in a week or two, not only I answered, but hundreds of the psychiatrists answered that call, and maybe even more important than just volunteering to pick up the phone, some other young colleagues contact her, and so thanks to Dr. Gautam Smithau said, well, I'm very good at administration. You're going to need an administrator to do this. Another colleague was Chinese American, had helped Chinese doctor and staff in Wuhan already and had that experience, and they offered the experience. Another offer for a website. We needed legal help. And in 2 or 3 weeks, this extraordinary group of women and men put together a physician support line, PSL, physician support line. And so, as I said, she asked for help mid-March, and on March 30th or 31st, which is Doctor Day, we were on, and we start taking calls. We start taking calls from all over the country. The beauty of the organization was that we were protected legally, because you have to make sure we had some form of protection, since we're going to pick up the phone and we're not able to answer in person, and it's an anonymous line, so we can also we don't know where the caller is. So we needed some protection for liability, but it's quite beautiful that psychiatrists from all over the country can answer calls from physicians from all over the country for all kinds of reasons. Often a caller asks me where I am, and most of the callers start by, we're not sure we should call, we don't want to bother you, we don't know if problem enough to call. But I realize also that they're very respectful. Say, are you in a state where you're overwhelmed? We don't want to overwhelm you more. It's also important for anonymity. In small states, most of doctors know one another, and sometimes work in the same institution. And we can understand that some colleagues could be concerned about speaking about their distress, their anger, their concerns about different things happening where they work. So it's quite beautiful to have that all over the US, men and women of all ages. This is also a beauty of our groups. We are now 500, 600 psychiatrists. A lot, in the US, 40% of, I think 25% of all physicians and 40% of all psychiatrists are foreign graduates. That means they study medical school, sometimes specialty abroad. Some from Europe, like I am, I'm part of them. I'm from India, from Africa, from England, from Lebanon. And so the mix of psychiatrists, and in particular the one who volunteered for this organization, is incredibly diverse. A lot of women, the majority, maybe because it started as such, men and women of all ages. So you have people who are just coming out of residency, and you have colleagues who have 40 years of experience, 50 years sometimes, old psychoanalysts, people who work in very different settings. And I think it's beautiful because we can answer either directly when someone calls us, or during debriefings, because we quickly the responsible realized we will need some ways to debrief one another. The calls we will receive are tough, hard. It's not easy to know what to say, or we've been taking in a lot. And so every Wednesday we have an hour and a half of debriefing, where of course everything stays anonymous. We don't give details, but we can share some concern or ask some questions. Remember, I had a lot of calls from Indian American women, and I was curious from my Indian American colleagues born in India or second generation here, some important thing I didn't know necessarily culturally. Report to work, to the couple, to the family. We had African American colleagues speaking, and of course all that happens also during Black Lives Matter movement. And we had, because we have the debriefing on Wednesday, and Saturday we have 1 or 2 hours of kind of teaching, lectures. A lot of colleagues offer to help us, teach us about mindfulness exercise, about trauma, but also about what they've been experiencing as physician. Think of our ER colleague, African American colleague, who told us about our own struggles and difficulties already before the pandemic, and even more now. So we had a big deal was people need to know about us, right? We were ready, but would the calls come? And that's not easy. And it was not easy because we need to let people know where to call us. We need people to trust us. We were lucky. We had, thanks to colleagues, we reached out. NBC did a segment on our work. We've been sending information to different organizations, and some calls came. But then what we realized is that it's very hard for a physician to ask for help. They were very happily surprised and happy that we were physicians answering the calls, and not in an arrogant way or, the physician can help physicians. No, but physicians who have been through training, who know about medicine, who know about what our colleague means when they speak about certain particular acute issues in a ER or in a ICU. They knew that they could share with us, and even if it was not our specialty, we had a sense of what were they going through, what was happening. A big issue in medicine is that you are trained very early not to ask for help, which is bizarre in a way, since we are asking people to trust us enough and to let us help them. But the training, the kind of macho, I don't know, maybe I'm sexist by saying that, shouldn't be a men thing not to ask for help, but it is this kind of culture of you need to be tough, you don't need to sleep, you don't need to eat, you come to work even if you're sick, you don't complain about it, you just here, you do your job. And it's always been that way. I think the difference has been probably been harder and harder in terms of younger doctor, not only having to do all these shifts. It's been changed a little bit. We supposedly cannot work more than 90 hours at the time, right? Maybe we have to do 72 now, except that in many programs we continue to do the 90-hour. We just ask residents not to disclose what they're doing, telling them that if they speak about the irregularity that they have to participate to, well, they just may not graduate from that residency program and not be able to go anywhere else. So some changes that have been done the last few years are for many, I would say, in words only. But the stress of the work, the intensity of the work without COVID, it's important. I just want to add one thing. Add to that for a young colleague that they finish med school with $100,000 of debts. So you cannot complain. You cannot really stop if you're exhausted, if the work has been too much, because you have now these $200,000 or $300,000 of debt. If you stop halfway, you're going to have to pay back this. And this and many other factors that require an entire interview themselves have done that at this point, the suicide rate among physicians is the highest among all professions. We lose between 300 and 600 before COVID, 600 doctors every year to suicide. 1 million people every year lose their doctor because of suicide. So this line we realize is super important. We need to teach people it's okay to ask for help. And we realize that we want to continue that even after COVID because it's such a need for it. So how we try to be known? Well, by contacting multiple organizations, telling them about us. Of course, they don't know us at the beginning, so they may not always be ready to vote for us. But the organizers and other volunteers have done a lot of work, sending, email describing what we're doing. We know some, because when we ask people how they found us, sometimes it's a paper in the ER room. What about residents? What about med students? And we have extended our services because we realized there was such a need to anybody basically on the path to become a physician as a resident or medical students. It's also an incredible level of suffering, of depression, some form of trauma for residents, a great competition among them. Medical students are kind of on their own. I spoke a lot with a friend who was in the military, and in the military at least they have this feeling that they have an esprit de corps. We don't leave anybody behind. Doesn't mean there's no competition problems at certain level, but they are trained, and she was telling me that recently again, we don't leave anybody behind, and we all know that we are a team. Tomorrow I may be the weakest link, and I may need someone, and it's about saving your lives. In medicine, you have this kind of exhaustive training, physically, emotionally, but you are so on your own because all kind of competitions, because you have in certain places, it's the custom that attending pimp you ask you a question basically to humiliate you in front of everybody. It's kind of breaking the spirit. Which, of course, when you go in med school with all these ideals that you're going to help people and you're part of this wonderful team, it's heartbreaking. And we have a lot of suicide of med students, of residents. That's a big taboo. And you add to that, to answer your questions, that if you seek psychiatric help, medical help, when comes the time for you to apply for your license, so after you do all the training, you pass all the tests, you have now to apply for a license in order to be able to work in the state where you work. And in many boards, in many states, in the majority of states still today, you have to disclose on your application the first time when you apply for your license, and or every 2 years when you have to renew your application for that license. In many cases, you have to disclose not only if you feel that physically, emotionally, you currently need help and maybe it create problem for you to be able to practice properly, which we want to know, right? We want to know if the doctor we consult is not demented, is not psychotic, is not severely addicted to something. So it makes sense, and that's where the board were created, to protect the public, and that's very important. So they look at, do we get the right training as physician, and are we able to work properly? And I insist on that because, of course, that's a given. The problem is, with time, these boards have been more and more intrusive. And so you don't have only to disclose if currently you feel you may be impaired. But if you ever in your life have been consulting, have medical or psychiatric problems, do you have a disability? Did you have a disability? Were you ever hospitalized for a psychiatric problem, for a medical problem? And in, again, a majority of states, still today, once you disclose, if you're honest, right, you just come out, you say, yes, I've been colleagues who've been sharing with us, a colleague who has been working for 30 years. She was hospitalized for severe depression when she was a resident. And after that, for the application to her license and for the next 20 years, each time she had to give access to all her charts, all the records, records from hospitalization, records from psychiatric consult, records from therapists, which normally are protected, right? All records are protected via HIPAA, but our records are protected, for instance, even vis-a-vis insurance. The therapist can keep, we can keep our notes, we can say what has happened, but psychotherapy notes are considered, and rightfully so, incredibly personal and private. Well, if you want to become a doctor, you have to give away the right for you to keep that protected. Not in all states, things have changed very slowly, but in a majority of states. So, of course, the result is that for so many med students, resident physicians, they don't seek help because they're terrified that they will not have their license renewed, or they will have to open all these records forever to a bunch of people. And I think many people heard of the tragic suicide of Laura Green, the ER physicians in New York, who had COVID and killed herself a few months later, a few weeks later. Our family has been very involved since in trying to change things for physicians. And her brother openly, I think, spoke to the New York Times or to other organizations, said that it was one of the fear for his sisters. Sister was a brilliant physician, absolutely brilliant person, who got sick, got not so much COVID also is influencing what's happening in the neurological level, and shared that she was worried she would never be able to work again. An example like that, I of course, many examples. And what do physicians do? Because they're still depressed, right? They are still not well. Say it's incredible amount of burnout. Well, they self-medicate for many, and you just make things worse. How do you self-medicate? You can literally self-prescribe. Antidepressants, already not recommended, but pain medicine, right? Get the pain go away. You can drink alcohol. You can use drugs. And in place of protecting the public, these rules were not nuanced enough, make the public, I think, create more danger for the public, and cost the life of so many physicians. Are suffering. If you suffer, if you're depressed, you're not as easily compassionate. It's hard for you, and put their life in danger. So, aware of that, we've been in contact with other organizations, so the women medical associations, the non-profit created by the family of Dr. Brian and others, and we're trying to help to change the laws. A few years ago, in Louisiana, some colleagues, I think, challenged the state of Louisiana and that law, saying that it was going against the American Disability Act. According to American Disability Act, you can ask about current impairment. You cannot ask about your past medical psychiatric history. They won in Louisiana. I know a colleague in Kansas just informed the board in Kansas about that. I don't even think they had to go through a lawsuit. The board in Kansas changed. The board in California still require for when you have a renewal to disclose past history of treatment. And many boards, not necessarily the state you would imagine. So there is a movement to try to change that. We'll see what happens. So because of all that, you understand how essential it is that the helpline is anonymous. And even if our callers know it's anonymous, at the beginning we were thinking, okay, we want to ask maybe the first name, what's their specialty, where they're calling from, just to have an idea where the needs are, right? Well, how can we address that? And then we realized that for many, they didn't want to tell us to worry. They don't want to tell us which state. They eventually must. You realize, okay, I'm an internist, somewhere on the East Coast, on the West Coast. But they were very concerned about that. And a lot for many, and that's what's so moving. Many of our callers never, ever try to get some help, psychiatric help. For many of them, it's the first time they reach to someone because they are overwhelmed. And when they are overwhelmed, they have to maintain, the moral. They are lots of head of a service, their work. I know some callers say, well, I'm the chief resident, or I'm the responsible attending in the ER, and then when I come home, I have my kids who are, we have to homeschool, and my husband is a physician too, but he lost his job because with COVID, you had an incredible number of physicians who lost their work because hospital didn't have enough patients. So you have this thing that the public don't imagine when we speak about doctor. They're close to bankruptcy. They may have to foreclose their home, and they still have those $200,000-$300,000 in debts, and what they're going to do. So the pandemic add to the usual already burnout because we don't have enough time to work with patients. We cannot do our job the way we thought we should. And having this ethics, going to medical school because you want to help, because you have a certain ethics, because you want to do the best for your patient. And then you work in a system where you don't have the time, where you cannot do all the exam you think should be done, where you cannot spend time speaking about diet, you just have the time of prescribing a pill, create another problem which has been identified as moral injury. And it's something that was identified initially in the military, where people who go in the military with the idea, want to do the right thing, end up killing children, end up doing things that go against their sense of ethics. Well, we have a gigantic crisis of moral injury in physicians. So, and that's why some of their fear, they don't want necessarily the administrator. No, they are seeking help. So there are things that are well known from before. One of the factors that has increased the burnout and the level of depression in physicians and residents are the factory-like work that they have to submit themselves to because they have no other place to work than big institution, big insurance company, big hospitals. And we have incredible charts where you see that because we speak about medical care, healthcare being so expensive, when in the last 30 years, in the 70s, the 80s, when we start changing the way we treat patients, the number of expenses for physician and nurse on the graph would go, increase a little bit, but barely. If you look at the expenses for administration, and I don't know, everyone else who live out of the work of the doctor and the nurse has been going like this, exponentially. So the healthcare system is so expensive because you have all these things in addition to care that they've been that people pay for, and to get all that money, what's expected now from the physician is more to do all this paperwork, all this chart documentations, all this checkbox that they have to do. And so a primary care doctor who should have an hour, 40 minutes, 30 minutes with a patient, who should have the time that's needed. Maybe we're done in 10 minutes sometimes we did 30 minutes. Primary care doctor have an incredible rate of burnout, who are among the lowest paid with the pediatrician in medicine. Have what, 10 minutes? Think of the last time you saw a doctor in an institution. So the fact that you have barely the time to look or to examine your patient, that you have constantly to rush on the computer to complete all what have to be done, because now you're doing the billing. No, you have to be billed in a certain way. You have to click or this, you have to ask these questions, not necessarily because it's useful for the patient, but because you have to do. That's been a major factor. That, the lack of time, the fact that the institution will not necessarily let you do what you think is necessary, ask for some test, again, make the patient come back sooner. You're not in control of your schedule in most of the places. If you're a physician, for instance, a psychiatrist, where in the good old time we would, of course, we prescribe meds, but we also listen. We take the time. We try to advise in other ways than prescribing pills. You have 15 minutes. You can do much. You have 15 minutes every 3 months with someone severely depressed. You cannot do much therapy. So you have to refer the patient to a therapist. And the patient may go or may not go there. But you cannot do your craft the way you think is the best way to do it. And I'll never forget, I was working for many years in a place where we had time with a patient. It was a county clinic. We get informatized very late, so we had still a possibility. But I know from some colleagues working in a similar system, they would say they see a patient regularly, the patient is better. They speak, they do a little bit of therapy, prescription. Patient is so much better, they stop the medication, and suddenly the patient doesn't show up to the clinic. And when the doctor looks what's happening, he's told by the secretary at the front desk, oh, you don't prescribe medication anymore, you don't need to see the patient. So physicians in general are very independent, hard-working people. They may be too independent or want to be, doing the thing in their way. And that particular personality was very good for a long time, to need to be autonomous, independent, resourceful, creative. All these qualities are basically not going well at all with a system who wants you to work as a wheel in a factory machine. So that's been a very big problem. And all these years, and the financial burden has been also a gigantic problem. And you cannot seek help. So that's been terrible. So some of the calls where you can imagine people call really at their limits, hiding from family because they don't want to worry them. They don't want to worry their kids. I remember some description of colleague calling from inside a closet, sobbing, exhausted, working, exhausted, not knowing how to pay for the house, how to take care of the kid, terrified of getting COVID, of course, because we don't get the protection we needed, right? No personal protection. That means you can die, you can kill your husband, you can kill your family. You see your colleagues intubated and dying in your own place. There is no support, most of the place. I think maybe some big university or hospital. I think Colombia, eventually they put some people from inside helping. But again, do you really want to share what you're going through to the colleagues who work in the department next to your department? It's an issue. We had a colleague calling because the understandable helplessness. We have patients coming in our ICU and they all die after 5-6 weeks. And then when I go out and I see people don't want to put a mask on, or I speak with my husband or my wife with a primary care, people come and ask, or leave so they don't have to put a mask. Or the politics around that has been also incredibly hard. You see people die, and then you have patients coming in the ER telling you, I know your hospital is empty, I know there is no COVID, I heard that you guys are putting COVID diagnosed so you get more money from Medicare, but there is no COVID. I have Asian colleagues being racistly insulted, yelled at, threatened because they brought the Chinese flu. So it's a horrible storm of so many things. There was a crisis before. It's a crisis. I mean, every day a doctor killed himself. At least that's the one we know. So there was a crisis. There was a crisis because they don't ask for help, because there are problem later on. You may not be able to keep your job, to keep your license. You have this financial problem, and then you finish working and you have to work in a system which is going against your sense of ethics. Burnout, wounds, emotional wounds, ethical wounds. So there is an incredible need now. There will be an incredible need in the future. We don't have as many calls as we wish we had. I think for many it's also sometimes too traumatic to speak about what's going on. And it makes sense. It's hard when you're in the middle of the trauma, in the middle of the war, to go too much and exploring too much the emotions related to what you experienced, because you may not be able to go back to work the next day. You may just quit. And that's another dilemma. Should I quit? But then I abandon all my friends and colleagues or risking their life right now. Some colleagues who had really medical issue made them at high risk. Diabetes, being older. We've seen in the doctor, when you look this heartbreaking list of health workers, including physicians who have died, you would be surprised and not surprised to see so many physicians coming out of retirement, 60, 70, 80 years old, sometimes because in rural communities, they have very few physicians. Coming out, they were dermatologists, they just want to do their duty, and dying from COVID. I think of the memorial of 9/11, would be a lot of memorials for a lot of people we've lost in this. So we don't have many calls as we wish, in quote, we wish because we wish we could help. And when we see for the colleagues who are brave enough to call us, what's a very moving moment is that we help them to identify what's going on and to identify the fact that they can get help. That's nothing to be ashamed of. It's actually very brave, that they deserve it. And if they don't feel they deserve it for themselves, they should do it for their patients, for their family, whatever works. And that, in fact, speaking to a shrink is not that scary. Because, psychiatrists don't have a good reputation among the people in general, right? We identify, and probably in the past was right, but that a bunch of crazy people going to hospitalize you and do their electroshock. I remember that kind of machismo among specialties and in medical school, and people go in psychiatry. So many, including myself, have been told by, the attending in surgery, in medicine, or why are you going in psychiatry? You're a good student. You're a great resident. Why do you go there? Like if psychiatry was something, below, like for bad doctors, for failed doctors. Then, of course, often they're the same people who criticize psychiatry, sometimes called you because the child is sick and they really want you to help. So we had this kind of stigma vis-a-vis our specialty that we were ourselves very aware of. I remember at the beginning of my work as a volunteer on the line, one of my fear was being my colleague working in ICU say, "You're not even a doctor, why should I speak to you?" Right? And I realized sharing that with fellow volunteers, we all had that fear. It never happened. It never happened. We were real. We are physicians. Some forget, some ask, "But you psychiatrist, so you really your doctor?" Because I want to tell you what's happening in my ICU with my patient. It's that patient who died today, the 5 patients who died yesterday. So I think it's very important for them to realize, wow. And because we have that diversity of psychiatrists, of all different accents and ages and training, often we tell the caller to thank us and we say, feel free to call again. After a while, we can say, well, maybe we'll try to find someone to help you in the states you work in. Again, and people get worried about licensure and all that. But it's really opening a door. And I really hope that for the majority of people who called us, they know this door is open and they will not close it too quickly. And if not now, maybe in 6 months, maybe in a year, they say, you know what, that shrink didn't seem that crazy after all. She was helpful. She could relate. I could relate. So I think that's very, very important. We're trying to get more known, but this is a work for today, and it will be so much trauma to address 6 months from now, a year from now, 5 years from now. It's very interesting also for med students, for instance, or residents. I don't really want to complain about the fact that some have been very protected, so they have no contact with patients, but others have been sent in the first line alone, or in places where they don't have the support they should have in an ideal system. I don't know if COVID made that happening. COVID again revealed more of this dysfunctionment in the system. So I remember a young caller who was a resident, second years in another state, and describing what she had to do in that outpatient clinic and doing something that was totally out. She was an internist and she had to do basically psychiatry. And I said, why is he asking you to do that? And I remember answering, he said, that's the point. Yes, thank you. And do you have someone, supervising you? No. Well, I say, of course you're stressed. I mean, that's incredible. Those are incredible, difficult circumstances. Oh, yes, thank you. So that validation for med student about their struggle, speaking to, when it's with me, with an old person from elsewhere who went through it, who knows, who don't feel they're weak because they're scared, or because they're angry at the system, who's very different what the medicine they dreamed of, who want to give up, and that we can examine with them. We're not going to make decision, or this horrible things they are in with, and still the fact that but there may be a different way to practice. They have to go through a certain drill, and do they really want to do that? Re-explore with them if they really want to do that in a way that they cannot do with a family, with pressure them to be a doctor, or with their attending. So it's not a doctor-patient relationship, right? We wouldn't be covered for that, right? So we cannot prescribe. We can prescribe medication. We're not supposed to give medication advice. Now, if something really seems incredibly dangerous, we can explore that, right? So we don't have a patient-psychiatrist relationship, which requires continuity and or kind of different set of circumstances. We cannot do it anonymously. But it happens, what we recommend, if you feel it's been helpful, you don't really have support, you may not be ready to call a psychiatrist or a therapist, of course you can call again. Very few people have abused it. We had a few out of the hundreds and hundreds of calls. We had a few calls. I had a call of someone who was not a physician, who had called multiple times and was very it was scaring the person on the phone, was eventually very racist, was eventually very threatening, because we had these calls too, and you don't know at the beginning if it's a very dysregulated colleague that's ready to kill himself, or it's someone who is, and we eventually learned for one, someone who was trying to provoke and make us state things that they were recording and work against our helpline, because our helpline is staffed by the face of our helpline are not just white Americans, they are all Americans. So we had a few calls like that. Coming back to the relationship, so if someone is calling again and again and again and hopefully tell us, we may want to explore that and say, well, we can help a lot, but we cannot be the therapist, the regular therapist. And we'll try to help that person to go and find more regular help with a therapist. We one of the difficulties about being an anonymous light, of course, and working with people who have a high risk of suicide is what happens if a colleague is telling us, I'm going to shoot myself in the head right now. You're on the other side of the line. We didn't have that level of difficulties, but we had to work ourselves and accepting what could be our limits or not. Is it possible to identify? The phone number is somewhere. I don't have it. Somewhere in the cloud. I think if it was an extreme emergency, we may be able to find the location where that person is calling from. We never had to do that. We have ourselves, when we are on call, we can contact one of the administrators. When I have two phones, I can text if I'm very concerned, or if someone else calls, we have a backup. So it's quite incredible that the organization was put together by physicians, by young psychiatrists, who had no experience in that before, and it's working. I just think that what has been moved the most is how far these colleagues can go and still work and still caring for their work, their life, Speak about, I'm sure colleagues their houses have burned, right? And it's like firemen whose houses burned and still go and do their work. What's breaking my heart is how far they have to go to ask for help. And how difficult it is, even if they find the path to us, for them to have access to care. Because, psychiatry is very poorly reimbursed. I mean, it's ridiculous. That's why psychiatrists in a big healthcare system or even Medicare have 10 or 15 minutes for a patient, because you get $40, $50, right? So most psychiatrists work in private practice, where it's much more expensive. So it's hard for colleagues to offer that. So many colleagues I don't know, you have a kid with ADD, you have a kid on the spectrum, you have your house to pay, your practice, and you already barely have the time, and you're gonna pay $300 a week to see a colleague. It's hard. So what's really, we used to have that system in Belgium, and I heard it was the case in Canada and here, where you were seeing a colleague or a family of a colleague physician, they would not pay you. It was free. Our service organization is Physician Support Line, PSL, Physician Support Line. And if you Google Physician Support Line, and you come to our website, another colleague, Alison, has been taking care of that website. And with time is also quite amazing. We have tons of resources now. We have links to mindfulness exercise or the lectures we've been receiving, us as physicians working on the line, are accessible. We have a YouTube channel now where you can see many of that, which can be useful for you working with your colleagues. We have books, texts, I know some colleagues offer once a week some mindfulness and meditation on Zoom for physicians. So you have a lot of mobilizations. And so yes, if you Google Physician Support Line, I know that you can find it.